get stuck into the glass slides like this, which you would then look at in the microscope. So what we do in our study right now is from these paraffin sections, we cut them and we actually manually dissect. So you take out the little pieces of tumor cells in there with the help of the microscope, of course. And then these are then digested, you extract DNA from that, and then that's where you apply your fluorescence in situ hybridization, and then you look at it in a different microscope. It's called a fluorescence microscope, which would then light up, and you'd see different colors. But it's complicated. It sounds complicated, but mainly what we're trying to find out is we're trying to validate some specific chromosomal abnormalities that we see in melanoma. So that's what we're doing right now, and it's a project that's ongoing with I believe 2 residents here and some of the other pathologists here as well.
Okay.
So yeah, so we're collecting specimens, all melanomas, and we're looking at that through this molecular technique. But
that sounds really interesting.
It's interesting. It sounds complicated, but it's not really. It's just labor intensive, but we have a molecular pathology lab here as well. So it's a big lab. And all they do is that it's basically testing on DNA, and they have different machines for that as well. So that's what we're doing right now.
Yeah. Do you have any reason why you chose to work in Harvard Hospital?
I chose to work here because I was trained here. So I did my residency training here, and so I spent 4 years as a pathology resident here, and then after that I spent 1 year training as a surgical pathology fellow. It's a fellowship in surgical pathology, and it was in Yale. And then after that I did my dermatopathology fellowship in University of Alabama, Birmingham.
Yeah.
So as I told you, it's a lot of training, but I wanted to come back here because, well, first of all, I'm familiar with the place. I knew the system, and I liked working with the people here. So these were all my former mentors who I now work with. So it's good to come back to somewhere familiar, and I wanted to stay in Connecticut too, because my family's here.
Oh, did your whole family move here, or is it?
We were here. We moved here from the Philippines a long time ago, but this has always been our home. So I thought I'd like to stay and practice here permanently.
That's nice. Yeah, I think that's all my questions.
Oh, good. We covered everything.
Yeah, I was trying to think of new questions, but
that's okay. You know, it's interesting, and I'll show you the lab. I'll give you a little tour later on, but it's nice for you to actually see how these things get processed, and I'll show you in a little bit how they get to this stage. It's a lot of steps in between, but you start with a skin biopsy. You know, for example, you have a bump here that's suspicious for not all skin bumps get a biopsy. For example, something that looks like an insect bite, you don't do a biopsy of that. But for something that's suspicious or concerning for a cancer, you do like a shave biopsy. So the doctor just takes a little piece of skin, which would then cut it out with anesthesia, of course, and then it gets processed into a block, which would then be processed into a slide, which I would then look at in the microscope, and I'll show you how it looks like.
I have a question. Like, did you ever have any instance when you had that, I guess, specimen of skin, and then you didn't know what it was?
Oh yeah.
What did you do?
So yeah, you do encounter specimens that just stump you, and you don't know what it is, and so you either I show it around. I do have other pathologists here who work in different areas of pathology, not in skin, but they also have experience in skin. So I show it to my more senior colleagues. I hit the books and see what's been written about these diseases, or I go and do my research online and see if there's anything that's been described that looks like this. There are things that you may not know exactly what it is, but you with your training and your background, you have a sort of an idea of what it is, or what the cells are, or what lineage these cells are from. So you have a sense of direction, and what you need to do is, and you don't have to really, I know that our job is to give a diagnosis, but there are diseases that actually defy classification, for some cases that have features that just are a mix of this 2 or 3 other diseases, so it's hard to pin them down. But in cases like this, you have I guess your main job is really to determine if it's benign or malignant, if it needs to be taken out, or if it's okay to just leave it in there for observation. I think that's your main job, and once you have done that, then I guess you've done your part.
Is there some instances when other doctors here gave like a wrong diagnosis?
Yeah, no one's perfect, and sometimes you can be misled to think that, oh, this is that, just because, for example, you got a very tiny specimen. It's a small portion of what is actually a big lesion, and if they did not give you a representative sample, then you won't really see the actual features of the cancer. For example, if they just gave you, for the biopsy, they just took the tip of that lesion or the edge of the lesion, then you won't really see the whole picture, and that would probably lead you to think that, oh, this is nothing, or this is probably not cancer. But then if they tell you, so that's why you have to have good communication with your clinician. If something's not making sense on what you see on the slide, you call them out and ask them, ask for the history, ask for any other background information. Is this patient sick of anything else? Does he have any other clinical history? Does he have a family history of this? Does he have a past history of melanoma? So you have to ask them that, and eventually you'll get a clearer picture. So yeah, it's not limited to just looking at the slides. You have to interact with the other clinicians as well. So it's a teamwork. But it's interesting.
Do you, like, your patients, what is the most common skin disease they have when they come to you, or?
So most of the cases that I see on my trays, as statistics would show, the more common carcinomas of the skin are still basal cell carcinoma and squamous cell carcinoma. So those are the ones that I see day in and day out. Every day you see them on your trays. And then there are...
What are they? Sorry, what are they?
Basal cell carcinoma and squamous cell carcinoma. Those are diseases of the skin, usually in older people in sun-damaged skin. So people who've been exposed to the sun for most of their lives without sunblocks, and you get these skin cancers that are clinically, they look like either bumps or nodules. They start out as tiny, raised irregular bumps, and then later on, if unchecked, they can be, big ulcers or nodules. So something as, something as big as this.
All this?
Yeah, these are the trays I look at. So this is actually an excision of a skin cancer. So it's a squamous cell carcinoma. You can already see how big, and it looks warty, right? Looks like a big papillary skin bump, with all those fronds protruding from the surface. So these are cut sections, so that's why you see many of them. So these are central sections that are cut like this, and they are sort of plastered on the slide like that. So you can see how ugly and big they are, even without the microscope.
Is the purple part blood, or is it?
No, that's actually there's a bit of blood in there. There's that's the crust that you see, or the scab that forms over it. So it looks red, and that's because of the dye that we use here for the slides. And the skin, or the blue area here, is actually the cancer. And I'll show you. Let me show you now. After we're done.
What is this? Is this just glass, or is this some special material?
These are glass slides. So these are paraffin blocks, and they get cut by a machine like that. So very thin sections, and then those little pieces of cut strips will be stuck to the slide like that.
Oh.
And then the slide will then go to a machine which would stain it.
Mm-hmm.
So it would be automated, it would go through different solutions, and it would get stained.
Mm-hmm.
And then finally it gets covered by, there is a cover here actually, so it's not just glass, there's a plastic cover
Mm-hmm.
slip. It gets a cover slip and then it's ready to be looked at under the microscope.
Mm-hmm.
Yeah. But I can show you the machine
Yeah.
later so you can have a better understanding
Do
of the whole
all
process.
the dermatologists, do they have this? Is this
So yeah, all the pathologists have
Yeah.
this. They have, so we have, I think we have over 20 pathologists here with
Oh.
different specialties. Like some people specialize in breast, like breast
Yeah.
biopsies. Some people specialize in GI or gastrointestinal biopsy. Some people specialize in hematopathology, which is the blood and the lymph nodes, so lymphomas, diseases like that. So we have different subspecialties here, and I just happen to be interested in skin, so I chose dermatopathology.
I kind of did a research and it
Mm-hmm.
showed that skin cancer is one of the most common cancers in America.
Mm-hmm.
Do you think you know any reason why?
I guess, as I said earlier, the population here, most of the population have fairer skin, which would then make them more susceptible to the effects of the sun, which would then lead to mutations in the DNA, which would lead to cancer in the skin. As you notice, people here are fond of the sun, right?
Yeah.
And they like to tan. So that's one of the factors. Another factor would be probably the age.
Yeah.
So as people age, or I think we have a good number of older people, or we have an older population. Those are the ones who actually are the ones who get cancer because of years of chronic exposure to the sun would facilitate that. So those are mostly our patients, or the ones that I see here are elderly patients with skin cancers. What else? I guess one of the reasons they say that we actually have a rising incidence of skin cancers right now. Some say that it's also a heightened awareness, right? People are more aware now, so people are coming to the doctors more often, and they're more conscious of these lesions. So that's one reason, I guess, heightened awareness and improved information on skin cancer. People know more about it, and they tend to be more conscious.
So how do you prevent it? Do you just go to the doctor more often and get checked, or do you just put on sunscreen, or?
Yeah, those are the usual precautions, especially for younger people like you. There's been a study that showed that skin exposure at a younger age actually would predispose you to getting skin cancer later on when you grow older. So it's crucial to get protection at an early age. So young children, especially when they're out playing sports in the field, they should get adequate protection by sunscreen, and that's one of the thrusts that we are promoting right now. For people, especially with the summer coming, for people to be more conscious and more to put more actually. So there is an ad that shows you how much sunblock you need to put, and it's the size of a golf ball. So that's that's the amount of sunblock that you need to put on all over before you go out in the sun. So and it has to be SPF 30 and above. So so the sun protection factor, it can't be below 30. So that's what we promote.
Is it recent that people started taking notice of skin cancer and the cause of skin cancer? Because like a few years ago, I heard from someone that when they were younger, they didn't know any of that, and they just went to the beach with their friends, for instance, and put on tanning oil, which is actually bad for you, according to research these days.